I'm Deji Adegunsoye from the University of Chicago, and I'll be talking this morning about sex and racial disparities in diagnosis and management of fibrotic ILDs. And over the next 15 to 20 minutes, what I hope to do is at least highlight some of the key disparities that we've noticed and observed in the last few years. So let's get right to it. These are my disclosures, none of which are particularly relevant to the talk today. But first, I want to state a few things. One is that many of the studies that I will be talking about today use the terms sex and gender synonymously, and whether the variables that were described were intended to really describe biological sex and gender is not very clear, but we'll take it in that context today. The second aspect is that race, as it presently stands, is primarily a social construct. And so we'll view it from that lens today as well during the course of this talk. But basically, by and large, the differences that we're going to talk about don't inherently mean disparities, but yet they can subtly give rise to disparities. And so we should be mindful of that as well as we talk today. Now, I don't need to describe or define fibrotic lung diseases to this crowd. We are very well aware of what parenchymal involvement entails. What I want to point out here is the challenges that we need to better understand with fibrotic lung diseases. We face an era where millions of people around the globe are impacted by the fibrotic lung diseases. And as the affected populations, families, caregivers, loved ones continue to increase with the burden of this disease, we should be mindful of the impact that disparities can bring to bear on this condition. We also think about the import of therapies, novel therapies, which we continually tend to push the boundaries on, trying to find newer pharmacotherapeutic interventions that can change outcomes for this disease. But as we do that, we should also think very carefully about barriers of inequity that can arise for this condition. And so we really should understand better and identify disparities where they exist to help improve outcomes for this disease condition. And so when we think about this, sex and race play very important roles in these disparities, as I'll highlight to you today as well. We already know that pulmonary fibrosis constitutes a significant health burden here in the US and across the globe. And what really is worrisome is the prevalence is rising. As you can see on the screen, there's been almost a 20% increase in its prevalence between 2010 and 2019, not just in the last few years alone. And this was before the pandemic. Now, unfortunately, with the link between viruses and pulmonary fibrosis, there's expectation that fibrotic-like conditions or diseases might also start to see a rise, an uptick in the prevalence across the globe. And that worries everybody. While the US prevalence of ILD is greater amongst female individuals, as we can see on the screen, the rate of change appears to be much faster amongst male subjects, which again is quite intriguing. Now, how much of this is due to underdiagnosis or suboptimal recognition of disease is unclear. But perhaps more worrisome than that is what I'm showing you on the screen now. Now, this is really elegant data out of Seattle, Washington, where they showed in terms of county-level mortality rates across the United States that there's been a doubling in the rate of death from pulmonary fibrosis. And in fact, in certain counties, that mortality rate has tripled. And that should be a cause of concern for everybody. And when we look at that in the context of racial disparities or sex-based disparities, that again becomes increasingly concerning as well. Now, disparities in care of patients with pulmonary fibrosis are very pervasive. I mean, they go through the entire spectrum from diagnostic delays to access to care to initiation and response to pharmacotherapies to additional interventions, lung transplantation. We can go on and on and on. So across the entire spectrum of care, of management for pulmonary fibrosis, there are real tangible disparities that need to be addressed. If we're going to dent the poor outcomes I just showed you, we need to intervene and do so early as well. Now, how do we do that? We need to recognize these disparities, identify them properly, and then address them with measures that we can implement to address them. An interesting aspect of these disparities that I'm showing you is the differences in sex and gender across the spectrum of ILD, the diagnostic spectrum, often intersect with race. So they don't appear in isolation alone, they are intertwined. Now, Deborah Asayag out of Canada, I think Toronto in Canada, led a very elegant study where she looked at 60 patients with diverse ILD forms. And they had over 400 physicians from 76 countries across the world look at these patients and assign diagnostic entities to them. What they found was there was a threefold increase in assigning the IPF diagnosis to men compared to women. So men were 3 times more likely to get diagnosed with IPF compared to females in that study. Now, autoimmune ILDs and environmental-related ILDs like HP, hypersensitivity pneumonitis, were much more prevalent in female individuals. Again, not very surprising in that context. But looking at data out of our own registry, the Pulmonary Fibrosis Foundation, the PFF registry, we also found something very similar. In fact, what was found was that in the PFF database, connective tissue disease-related ILD, the autoimmune-related forms, was 4 times more common in black individuals compared to other individuals. Again, this is quite interesting, but what was perhaps more striking in terms of the intertwined relationship between race and sex was that black patients who had these autoimmune forms were disproportionately female. Again, goes back to the biology of the disease, and sex as a biological variable becomes to rise to the fore when we think about it in that context. How about diagnosing pulmonary fibrosis? Well, there's been recent recognition of inaccuracies in pulse oximetry measurements across board for patients with ILD, but even in the COVID era, which just recently came out of, patients with darker skin tones who have low oxygen saturation seem to have inaccurate pulse oximetry measurements. And this is really concerning because in certain subpopulations, up to 8 percentage points difference was noted with factitious increase in the pulse oximetry measurements for these individuals. This is so much so the fact that the FDA just recently issued a directive to the general public, because of this delayed recognition and the impact itself on mortality, on initiating therapies for patients with lung disease. I was really heartened earlier on this morning to hear Dr. Karimi Shah talk about, the focus of the NIH on this, and Dr. Martin Craig also talked about pulse oximetry devices and how we're funding or looking to fund more research into this area to improve precision for these indices. So it's really important because, again, a cardinal metric in pulmonary fibrosis diagnosis and management is recognition of hypoxia. It's a key marker for this disease. How about in diagnosing pulmonary fibrosis, again, looking at the pulse oximetry and looking at PFTs in this context? Another aspect that has really come to light is the disparities in recognition of disease, particularly with lung function impairment in PFTs. What we've noticed is that many spirometric measurements for patients with lung disease have separate equations for white individuals, for black individuals, for Hispanic individuals. And we often would apply race correction to obtain predicted values. Now, what does this mean? So values that may be deemed to be abnormal in white populations are deemed normal in minority populations. Now, this again, as we can imagine, has potentially devastating impacts on the health outcomes of people who are diagnosed with this disease or who have lung function impairment but don't get it recognized based on the PFT race correction. So a question we asked ourselves recently is, do race-specific PFT equations impact the eligibility for key interventions in pulmonary fibrosis? And to answer this question, we went to the Pulmonary Fibrosis Foundation registry, which has over 2,000 patients with pulmonary fibrosis. We stratified patients based on their self-identified race or self-reported race and ethnicity. And we first calculated their percent predicted lung function, the FVC, based on these metrics. We did this based on a race-specific equation, the most common equation, the Hankinson's 1999 equation, and then recalculated the FVC based on a race-neutral equation, the GLI Global 2022 reference equation. Using these results, we evaluated their eligibility for 2 key aspects of pulmonary fibrosis management, eligibility for clinical trial enrollment and eligibility for antifibrotic therapy. So what did we find? There we go. So the results were very intriguing. We found that using race-specific equations resulted in substantial misclassification amongst the different racial groups. So for clinical trial eligibility, as you can see on the screen, we found that 22% of black individuals, 14% of Hispanic, and 12% of white subjects were misclassified using the old equations. When you use the newer equations, you have increase in the proportion of appropriate classification of these individuals. The same thing was found for antifibrotic therapy. 21% of blacks, 17% of Hispanic, and 19% of white subjects were misclassified again for antifibrotic therapy. So So this shows that the use of race-specific equations can lead to delayed diagnosis. It can lead to suboptimal enrollment in clinical trials. It can lead to inadequate provision of treatment, appropriate treatment for patients with a diagnosis. How about disparities in treatment of the fibrotic ILDs? Well, we now know that geographical differences exist in the frequency of ILD subtypes across the globe. For example, while IPF here in the US constitutes about a third, 33% of all ILDs, in France, in Greece, in places like India, it's much less prevalent. But given the variation in ILD subtypes across sexes, it will be reasonable to anticipate that there will be differences in types of treatment for these patients. But in a study that was published earlier this year by Deborah Asayag in CHEST, irrespective of the type of treatment administered to these patients with ILD, irrespective of the ILD subtype, the proportion of patients treated across board appeared to differ significantly by sex. What was found was that there were more males than females treated in Canada, more females than males treated in Chicago, and very similar proportions treated in Australia and New Zealand. Again, it points to the geographical impact of ILD prevalence and treatment practice patterns amongst care providers across these different locations. On the right-hand side of your screen is also very elegant data by Bhavika Kaul out of UCSF, where they showed again that females with IPF tend to have a lower prevalence of treatment with antifibrotic in the disease condition amongst veterans. So even in the VA population, we see those disparities in treatment for patients with IPF. Now, quantifying differences in response to therapy can be quite challenging to model. We have restrictive spline models. We have time-varying covariates. You can apply different models using immortal time bias to account for that. But looking at it very simply in a vanilla form, we tend to occasionally favor the use of rituximab in treating those who have autoimmune-related forms of ILD. And so what I'm showing you on the screen is a large case series across 2 hospitals where patients with interstitial pneumonia and autoimmune features were treated. And these are patients who received rituximab for treatment. You'll see on the screen here that while there seem to be differences in the proportions of females treated, the outcomes were largely positive. Most patients who were treated either got clinical stability or clinical improvement in their lung function with rituximab therapy. Again, it places importance, underscores the necessity of treating impairment in lung function when it's present, because these patients should get it. So with the full recognition of sex as a biological variable in ILD, we realize there are differences in clinical presentation, in severity of disease, in progression of disease. And of course, we think about genetic, hormonal, environmental impact that contribute to these sex and gender differences across board for these patients. But how about outcomes? How do these patients fare? Are there disparities in outcomes? Well, you can see again that mortality appears to be different between sexes. Males with IPF or systemic scleroderma ILD-related forms appear to have a much higher mortality than females. I'm showing you Kaplan-Meier curves on the left-hand side that depicts this very fact. And we also notice that there seems to be in larger case reports and larger retrospective cohort series that females with RA-ILD, the ILD form linked to rheumatoid arthritis, or those with lupus, systemic lupus erythematosus, seem to fare worse in terms of mortality than their male counterparts. Now, the reasons behind this are still unclear. We don't fully understand why. But at a minimum, it appears to be a multifactorial etiology in both cases. A few years ago, we asked the question then, does race impact outcomes in pulmonary fibrosis? We performed in Chicago a multi-center retrospective analysis of over 1,600 patients with diverse forms of fibrotic ILD. And we did this over a 10-year period. Looking back at this population, we found to our surprise that African Americans appear to have slightly increased life expectancy, even after adjusting for different severities of disease. The most striking finding, however, was that although patients who self-identified as being black appeared to live longer for about 1.5 years than their white counterparts, their diagnosis of pulmonary fibrosis or ILD occurred about 10 years earlier compared to other individuals. So there was a net loss of about 8 years when you compare these individuals to white and other Hispanic individuals. So again, that really points to a huge disparity in outcomes. But you could argue, is this a Chicago-centric effect? Well, we looked at 2 other locations across California, in Texas. We found exactly the same pattern, where there was a huge discrepancy between the age at diagnosis for black individuals compared to white and Hispanic individuals. Now, we went ahead to look at these findings elsewhere because we wanted to ensure that these were truly representative of the continental US, not just specific geographical locations. And so we applied a derivation replication approach where we merged all the existing cohorts into one and looked to the Pulmonary Fibrosis Foundation registry to see if we could recapitulate these findings in the registry. And what did we find? Again, the results remained consistent. Black individuals had the youngest age of diagnosis at the time of fibrotic ILD diagnosis. But what was perhaps more striking was it went beyond diagnosis. This disparities appears to be pervasive through the life course of individuals, where it impacted not just the diagnosis, but age at hospitalization, age at lung transplant, even age at death, consistently across board through the PFF registry. Again, this is really important because we think about these disparities and how it can impact quality of life, impact response to therapy, impact outcomes for these populations as well. Now, naturally, you might be right in arguing, well, maybe these results are skewed by a specific age group, and that is a very valid concern. And so we performed a sensitivity analysis, subgroup analysis, substratifying by age in deciles. Again, we found the same thing. For all outcomes assessed, the disparities occurred consistently, pretty much across all age groups that we looked at. So we often look at genetic susceptibilities to pulmonary fibrosis as a key determinant of risk, disease risk in pulmonary fibrosis. Now, a critical issue there has been that there have been very few racial and ethnic minorities enrolled in these studies, in these trials to date. I'm showing you GWAS data, genome-wide association study data, that show very, very little enrollment of black individuals, minority individuals in many of the genetic studies to date. So we can do better, we should do better, because we know that black race in of itself predicts high rates of respiratory impairment in COPD, in asthma, in pulmonary sarcoidosis. And so getting these patients enrolled in clinical studies, genetic studies, so we can better understand disease pathology is really important. Now, a great example of this is seen in differences across an increasingly valuable genetic biomarker, that's the leukocyte telomere length, which you'll hear a little bit about later this afternoon. This was a recent study in over 7,000 individuals, about 2,000 of whom had pulmonary fibrosis, and about 5,000 control subjects. We found that while telomere length is shortest amongst control populations, the patients with pulmonary fibrosis tend to have shorter telomere lengths, and white individuals had the shortest telomere lengths of all. Black individuals had the longest telomere lengths. Again, this may be reflective of the age of diagnosis, but there are certainly other factors that play a role in this. Now, there were also distinct sex-based differences that were observed. Females had longer telomere lengths compared to their male counterparts, and these differences, this wide divergence in the telomere lengths, were much more pronounced in those with fibrotic lung disease. What I'm showing you here is kind of a fancy Rubik's Cube, but really it's a matrix of odds ratios where we've plotted the risk factors, the impairment factors, factors that predispose to risk in fibrotic lung disease on the y-axis. And on the x-axis, you have age in deciles. What we found is that younger individuals, white individuals, Hispanic individuals, had much lower odds for autoimmune-related forms of connective tissue disease, for the connective tissue disease forms of ILD based on this data. So we talked a bit about gene-by-environment interactions, and many of us who call the US home would recently remember the Canadian wildfires, the Californian wildfires at least. And we think about the detrimental effects it has on respiratory function. In fact, many of our patients found it really difficult, challenging to breathe during those situations, during those conditions. And so the question then is, does air pollution itself increase susceptibility to pulmonary fibrosis? And is there possibly a gene-by-environment effect that we can bring to bear or understand better with these air pollution risk and fibrotic lung disease? So a team of North American researchers led by Gillian Gooby out of Vancouver recently looked at that. They investigated the exposure with air pollution factors linked to fibrotic lung disease. And they looked at baseline severity, they looked at disease progression, they looked at mortality amongst patients with diverse forms of ILD. What they found was that the risk of death was dramatically increased and greatest when the PM2.5 thresholds exceeded 8 to 10 micrograms per cubic meter. Now that's little actually, and that's quite concerning. In a recent editorial, they then advocated for looking at socioeconomic factors that could intersect with this risk and how we can possibly intervene to mitigate the risk and improve outcomes down the line. So therefore, much of our findings in race then can be possibly thought that maybe this is linked to environmental pollution. Are there environmental exposure interactions, such as air pollution, that may increase the risk for the populations we found? Well, we don't know yet, but recently we made some important progress towards that. We pooled Chicago-wide air pollution data, and we found really stunning results. When you look at black and non-black individuals with pulmonary fibrosis based on their residential location, these values are accurate to a kilometer squared. We found stunning differences in the prevalence of air pollutants for black individuals compared to non-individuals. For all air pollutants looked at, PM2.5, nitrates, sulfates, ammonium, black carbon, organic matter, sea salts, you name it, soil, there was a striking difference between the air pollution exposure for black individuals compared to non-black individuals. And this was consistent across board. I'll tell you also that this has also recently been replicated outside of the US in Canada as well. So we should perhaps start thinking about what interventions can we do to mitigate the risk that air pollution brings to bear on the risk of pulmonary fibrosis. If we're going to make any progress at all, if we're going to address these disparities, if we're going to make a change in the sex and racial disparities, a large part of it really, in my mind, begins with defining the problem. We've got to identify where is there a problem, can we intervene in this problem? And really it means paying attention to the things that matter. Clinical trial design, research intervention, registry enrollment. The little things that where defining the problem really starts. And possibly we can start to intervene for a positive outcome. When we do that, we can better define the risk factors, some of which I've listed on the screen here, for disease, risk factors for progression of disease, risk factors for poor outcomes, and possibly begin to leverage those positive factors that have been linked to good outcomes, to positive outcomes in the disease. That way we can truly begin to make a progress towards improving outcomes in pulmonary fibrosis. Now, I'll conclude by saying here that recognizing these disparities is critical to improving diagnosis and patient outcomes. There are changes that we can bring to bear, systemic healthcare changes, to ensure equitable access for patients in terms of management strategies and also outcomes for ILD populations. There are actionable knowledge nuggets that we can also bring to bear to ensure better quality of life for ILD patients. And there's a vital need to translate this disparity data into strategic ILD prevention and intervention protocols as well. This is our wonderful ILD team at the University of Chicago, without which a lot of this work would have been entirely impossible. And you can see, as Dr. Cass mentioned earlier on, we have an all-hands-on-deck approach. We have toddlers, we have little kids in the fight against pulmonary fibrosis. So we're grateful to a lot of people, funders, supporters, but above all to the patients with pulmonary fibrosis, because with you, we're stronger in this fight because of you. So thank you.
I'm Hyen Kim. I'm the ILD Program Director at University of Minnesota. And my talk today is centered on neighborhood disparities and impact of rural-urban location on outcomes in pulmonary fibrosis. It's a really long title, but actually the amount of data is small, but expanding. So I think this is a more recent development in ILD research, is to look at disparities, racial and sex disparities, and geographic disparities and neighborhood disparities. These are my disclosures and objectives. So we're going to talk about impact of rurality and neighborhood. And rurality basically is residents in a rural area. We'll talk about how rurality affects health in general, mortality rates and lung health. We'll also talk about impact of rurality specifically on ILD, its impact on ILD diagnoses, and from the work we've done with the PFF patient registry, its impact on access to outcomes and access to care and ILD outcomes. And then we'll also talk about neighborhood disadvantage and how that affects ILD in terms of access to care and outcomes. And then at the end, we'll just briefly talk about whether there's perhaps an interaction between rurality and neighborhood. So for background, let's talk a little bit about rural health. So the CDC estimates that about 15% of people in the US live in rural areas. They just updated this statistic in May of this year. 2010 census, it was 19.3% of the US population who lived in rural areas. So how do we define rural and urban? When we say rural and urban, what do we mean? So basically, rural is anything that is not urban. So urban is small, medium, and large metropolitan, and rural is everything else. And the terms are micropolitan and non-core, but the simple definition is rural is not urban. And there's a little bit of discussion about, well, what is suburban? Is that rural or is it urban? So that is still a little bit unclear. What we do know is that there is a difference between overall health in rural versus urban areas in the US. And this is reflected in overall mortality rates. So what this graph shows is mortality rates in the US over time. The good thing is that mortality rates have decreased over time across the board. So this is overall mortality rate. However, look at the black and gray lines. So the black line is rural mortality rate, overall mortality rate. Granted, it has dropped over time, but if you compare that to the gray line, that's the urban mortality rate. So there's been a widening of this discrepancy in rural versus urban mortality rate. The other lines are looking specifically at urban versus rural males, which are red and orange lines, and urban versus rural females, which are the navy and the aqua lines. So again, all mortality rates have decreased in the US over time, but there remains a discrepancy, and you can see the widening discrepancy in mortality rates between rural and urban areas, and even when you look at male or female urban versus rural. So specifically, let's talk about lung health in rural areas. We know that COPD, which is a chronic respiratory disease, is more prevalent in rural areas. This map shows prevalence of COPD by county. The bluer counties have a higher prevalence of COPD. And what you can see is that the blue counties where the COPD prevalence is higher overlap with rural counties. So there is an impact in rural health because COPD is more prevalent. We also know that not just diagnosis, but lung health outcomes seem to differ, and perhaps access to care in rural areas. So specifically in COPD patients in rural areas versus urban areas have higher rates of Medicare hospitalizations and deaths. When we look at another chronic lung disease, lung cancer, mortality rates from lung cancer are higher in rural areas. Actually, cancer rates across the board seem to be higher in rural areas. The reasons for this are likely multifactorial, and there's a lot of research. But one possible factor that has been posited is perhaps decreased access to pulmonologists in rural areas. So specifically, are there disparities in ILD when it comes to geography or neighborhoods? So up until recently, there was not a lot of work done in terms of geographic differences in ILD, whether diagnosis, access to care, or outcomes. But more recently, there's been more work and publications, and some of the authors are here in the room. For example, so one study showed that rural residence itself seems to be a risk factor for IPF diagnosis. Whether this is an environmental exposure issue is unclear, but that's a possible explanation. Another single center study looked at access to care, and one of their criteria was antifibrotic use. And what they found was that rural IPF patients had a lower rate of antifibrotic use compared to their urban counterparts. Again, this was just IPF patients. However, the drawback to this study, or I should say the limitation of this study, is that only 7% of their study cohort was rural. And if you remember, the most recent CDC estimate is that 15% of the US population lives in rural areas. So there was an underrepresentation of rural patients in that study. When we look at neighborhood discrepancies, so not just rural versus urban, but when we focus on specific neighborhoods and socioeconomic status, we do know that there seems to be an association between neighborhood disparities and outcomes in lung disease. So specifically, the Spiromics study of COPD patients. What they found was that neighborhood level socioeconomic status helps to explain partly the racial disparities in COPD patients in spiromics in terms of their quality of life and symptoms. And I find that very interesting, that combination of race and neighborhood and socioeconomic status. We also know a little bit about at least mortality in ILD and IPF patients when you assess neighborhood disparities. So, for example, one study showed that mortality from chronic respiratory diseases, including ILD and IPF, seemed to be higher in counties with worse social vulnerable index. And this takes into account some socioeconomic factors, but also cultural factors, social determinants of health, including SES, household composition and disability, minority status and language, housing type, and transportation. So these are all factors that might not necessarily be considered medical factors, but they're social determinants of health that can affect not just symptoms and quality of life, but perhaps outcomes. So this takes me to another measure of neighborhood disadvantage, the ADI, the Area Deprivation Index. This is a number that's been developed to study differences in neighborhoods and to measure social determinants of health. So ADI, or Area Deprivation Index, is a measure of socioeconomic disadvantage. So what does it actually consider? It considers income, education, employment, and housing quality. And this is, if you look on the website, and if you're interested, I can tell you the website. You can get the ADI for any neighborhood in the US. So it is that specific. The ADI is calculated for what are called census block groups, which are basically neighborhoods. And how it's defined is it's calculated on a numerical range. So the range usually is 1 to 100 when you read publications. Some publications actually go higher. The higher numbers denote more neighborhood disadvantage. So how does this apply to the PFF? So the PFF was very gracious in letting us use the patient registry. And as we know, the PFF Care Center Network is a national network of sites of sort of excellence for ILD across the US. So notice that most states have at least one Care Center Network site, a PFF CCN site. However, you can also see in light blue, there are still many states that don't even have one site. And if you notice, these states also have a large rural geography. So the background of our study is that there hasn't been, until recently, a lot of information about geography or neighborhood disparities for ILD and IPF. So our question was, what we want to study, does rurality or neighborhood disadvantage impact diagnosis, access to care, and outcomes in ILD patients? So we use the PFF patient registry, and as you know, the registry includes about 2,000 patients with ILD in the US from multiple sites. We used the CDC definition of rural versus urban. So rural is anything that isn't urban. And we had two hypotheses. Our first hypothesis is that rurality adversely affects access to care and outcomes in ILD patients. And our second hypothesis focused on neighborhood disparities. So our second hypothesis is that neighborhood disadvantage adversely impacts access to care and outcomes in ILD patients. So what did we find? First, we had to define how do we measure access to care. And we really wanted to use objective measurements that could be replicated in other studies or other projects. So we looked at specific tests and treatments that were available and that were codified or documented in the patient registry. So we looked at number of PFTs per patient per year, number of CT scans, number of ILD clinic visits, access to pulmonary rehab, access to supplemental oxygen use, access to antifibrotic medications, and access to lung transplants. Again, we wanted to use measurements that were documented in the registry that could be replicated. How do we define ILD outcomes? And so I think these are outcomes that have been used by multiple research papers and research centers and study groups. So we looked at overall mortality, we looked at lung transplant, acute exacerbation, and respiratory hospitalization, and did a time to event analysis with one or more of these outcomes. So these are the demographic characteristics of our study cohort. And I think it's interesting to look at the characteristics because it really defines the cohort and what makes this cohort different or similar to other study cohorts. So as you can see, the mean age is in the 60s, which is true for IPF, but realize that the patient registry IPF demographic is only about 60% or so. The other 40% is all other ILDs. The other thing is that it is largely white. The vast majority of patients in the registry are white. The other thing to note is that about 12% of patients in this registry are rural. It's a little higher than other studies of ILD patients, but it doesn't quite get up to that 15% of the general US population. So these are the study demographics of our study cohort. There were 1,640 patients, and it's not the entire cohort because of missing data. So the first thing we looked at was we did a cross-sectional analysis of ILD diagnosis in the registry and differences between urban and rural patients. So what you note is that we looked at different diagnostic categories in the registry. As you know, patients are put into categories including IPF, idiopathic interstitial pneumonia, not IPF, fibrotic hypersensitivity pneumonitis, exposure-related ILD, and then others, this category of other ILDs. So what you notice is there's a significant difference in ILD diagnosis, and again, this is a cross-sectional analysis between rural and urban ILD patients in the registry. We found that fibrotic HP and exposure-related ILD are more prevalent in rural areas. Is this true in other countries or other parts of the world? Well, there is a study from India where they also note a higher prevalence of HP in rural areas. Whether this would apply to other parts of the globe is, we don't know yet. So then we looked at access to care in rural ILD patients in the registry. It's a lot of data, but I'll point out the highlights. It's really interesting to me that there were some measures of access to care that were different between urban and rural patients, but many measures of access to care were quite similar. So for example, if you look at antifibrotic use, no significant difference between rural and urban ILD patients. So what differences did we find? There was a decreased number of hospitalizations and ED visits in rural patients as opposed to urban ILD patients in the registry. But when you look at other measures, like number of PFTs or chest CT scans, there really were not significant differences between the two. And we can talk in the question and answer session of why that might be. So there were some differences, but access to oxygen, lung transplant, antifibrotic use, not statistically significant. So the next slide, I'm going to walk you through this table. It's the time to event analysis for our study cohort. So we did different time to event analyses. We looked at overall death or transplant, time to acute exacerbation, time to death transplant or acute exacerbation, time to first respiratory hospitalization, and then measures of disease progression, or what we use, including decrease in FVC and time to decrease in DLCO. Not much difference. So I don't have a pointer, but if you look towards the bottom, you'll see urban versus rural. There was no significant difference in outcomes, in any of the outcomes in time to event analyses. Did we see a difference in other measures? Yes. So notice the bottom row of the table. It's the ADI, the Area Deprivation Index. So what we used as a reference group is the 10% most disadvantaged patients in the registry. And if you look at ADI papers, that they actually use 10 to 20% reference as the most disadvantaged, and then compare it to that group. So we designated the 10% most disadvantaged, or the 10% with the highest ADI as our reference group. So that's a reference group. When you look at all others, so all others are ILD patients in the registry with lower ADIs, so they're less disadvantaged or more advantaged. There was a statistically significant difference in outcomes. So the less disadvantaged ILD patients had a higher or a longer time to a couple outcomes, including time to death or transplant and time to death, transplant, or acute exacerbation. And I was talking to Deji, actually. I find this interesting also. There's a difference between male and female outcomes in the ILD registry, and that's in the middle of the table. Males had a longer time to event for most of the measures, meaning that they did better than females. And he asked me why. I'm like, I don't know, you're the expert. But I found that really interesting. There seems to be a sex difference in ILD outcomes in the registry. And again, remember, these are IPF and all other ILD registries. And then lastly, towards the top, I highlighted in yellow, patients who are younger with ILD do better. They have a longer time to these outcomes, including death, transplant, acute exacerbation. And I guess that makes sense, although there's some other data that suggests that younger patients with IPF actually do worse. So the differences we saw related to neighborhood disadvantage, sex, and age, but not to rurality, which I find very interesting, and we can discuss why that might be. So conclusions, fibrotic HP and exposure-related ILD are more prevalent in rural areas in this registry. Rural ILD patients had fewer ILD clinic visits per patient per year and less access to pulmonary rehab. So there was a little bit of difference in access to care. In addition, the rural patients had less frequent hospitalizations and less frequent ED visits compared to their urban counterparts. However, despite these differences in access to care, ILD outcomes did not seem to differ between the two groups. And then lastly, the less disadvantaged ILD patients in this registry had longer time to some of the outcome data in the time to event analysis. So I think in summary, rural patients in this registry do have some differences in access to care, but that doesn't seem to translate into differences in outcomes. But we did see difference in outcomes based on age, sex, and neighborhood disadvantage. Thank you.
Hi, so again, I'm Starlet, and I'm gonna talk about some of the financial disparities that occur with ILD and pulmonary fibrosis, including specialty pharmacies, 340B programs, and then how to finance new therapies in pulmonary fibrosis. These are my conflicts of interest. And so I am a nurse coordinator, so I work kind of a different level with the patients than probably a lot of you guys. So as treatment is prescribed for patients, that's really kind of where I step in to handle all of the back end portion of it. And there's a lot of things that we see that patients across the board with advanced lung diseases need help with, and some of those are help with access to treatment. This can be insurance-based cost, having no insurance at all, understanding how to finance the treatment, and then what resources are available to them, and many more resources that we actually do need. Barriers with helping patients with this, I think number one is time. In our day, most of our time is spent in patient care, which limits the amount of back-end time we get to have. Prior authorizations, helping patients actually get the medication first is very time consuming. If the medication isn't approved by insurance and it has to go through an appeal process, this can take an extenuated amount of time for the patients, and longer access to therapy, and a lot of burden on the staff. And then resources. I don't know about all of you guys, but we do not have an outpatient social worker, which I think is something that is desperately needed across pulmonary disease. So as nurses, we work and we kind of wear a lot of different hats as far as helping them, being an insurance specialist, helping them with diet, nutrition, helping them find access and work in that social work kind of area. And the other big thing is having knowledgeable staff. The pandemic hit everywhere pretty hard, and there's been a lot of turnover. And every time that this happens, there's a lot of training to do. So I have served in this role for 8 years, and I think it took me probably about a third of that time to really get comfortable with what I was doing and really understand what resources I had, what I could share, and what I could share with staff. So part of my goal with this is to let you guys know all the resources I use and if there's anything that you could take back to your programs that could help you. So one of the first big things is specialty pharmacies. This works very different for patients, and this is really hard for patients to understand, so we spend a lot of time talking through this. And most of you are probably pretty familiar with specialty pharmacies, and these are some of the ones that are aligned with the antifibrotics. But these guys, I think, are really special. They help. They're an added person to the care team. I speak with patients and I tell them, this is somebody else involved in your care. So with the antifibrotics, they will distribute, they can help with cost, help direct towards resources. When you get into treating pulmonary hypertension with ILD, they provide pharmacy nurse support, which is huge, and we have built really, really good relationships across the board with these pharmacies. If there's any way that you can get direct contacts and make it easier on your life to go back and forth with them, that's the best thing to do. But they are really involved. They will help let us know if something's going on with the patient, and remind us politely if prior authorization or an appeal is still pending, so we can get patients on medication as quickly as we can. So the medication gets prescribed, we send it to the specialty pharmacy, and then what happens? They call the patient and they tell them, this is your copay. And a lot of times it's a pretty big number that I don't think any of us could afford. So one of the things that I let patients know when we talk about this together is the first thing I tell them is when they call you and they tell you a number, like, don't get scared and just let them know right away, I can't afford it. And I make sure that they know that this is not something to be embarrassed about or scared about, that this is something that happens to everyone so that they know that it's okay to ask for help. A lot of the specialty pharmacies actually have a patient advocate that works within them that can help guide them to resources to help pay for medications when they can't afford them. And then the next thing I will do is help refer them to grant programs. So these are the nonprofit programs. This page actually comes from our MedEd Center website, which we update weekly based on what's open and closed for different disease states in pulmonary. The grant programs open and close periodically based on funding they receive, and they're broken down all by disease state. So this is just a portion of the diseases they cover, but they can be very helpful for patients. I want to say almost all of our patients go through a grant program because in this disease, you know, a lot of patients have public insurance, they have Medicare, they are not able to use copay assistance or coupons from manufacturers. So it's really big that they understand that this is a resource that they can use. They also have programs that you could hit that are on other diseases, because as we know with treating older populations, this is not the only thing we're treating them for. They may have asthma, they may have COPD, they may have cancer, lots of things to go along with it, and our cost of treating our problem is just a portion of what they're dealing with. So when you add it all together, this can be huge as far as getting patients access to therapy. Assessia actually has programs for private insurance as well as public insurance. They have different programs as far as to help pay for cost of medical treatment, as far as like doctor's visits, hospital visits, things like that, not just drug cost. The Patient Advocate Foundation is another one that has special resources for health equity funds. So those are funds that are based on areas that are underserved and need a little more assistance. So they have special programs for COPD in those areas, heart failure, things like that, that you could also help your patients with. So to qualify, they have to qualify financially, which a lot of our patients do, but sometimes they don't. So they have different metrics with each one, but they're normally between 300% and 400% above the poverty level, and they have to reapply each year. And this almost always requires something from the office. So it can't just be the patient saying, hi, I have pulmonary fibrosis and I need help. Then they require their doctor to also say, yes, I agree, and this is the right thing for them. This is just a QR code to get to the form that I just showed you. Like I said, we update that weekly, so if you are having issues getting patients with funding, I would urge you to use it. It's out everywhere for everyone to see and use. So once we can't use a grant program because they either don't have funding open at this time. The next step we really is try to work with patient assistance programs through the manufacturers. Again, if they have private insurance, so commercial insurance through their job, which is normally your patients that are under 65, or if they're still working, they're able to go for copay cards. But for those that are with public insurance, which is your Medicare, Medicaid, or government insurance plans, they are not eligible for coupon cards, so they have to be referred to either a grant program or to a patient assistance program. These are very, very, very helpful and have helped a lot of our patients be able to afford therapy. The big thing that I would say to know with these is if ever you're prescribing a medication that ask for a patient signature, get it. Because the only way that they can help them is if they have permission to talk to your patient. So sometimes that can be a barrier and cause a little bit of delay if the patient hasn't signed and is able to, they're able to speak with them. And so if we can't get them help any of those ways, then we can try to do other things. Like I said, getting copay assistance for non-pulmonary fibrosis medications. Inhalers are very costly to patients. There are working with pharmacists to help go through all of their medications to lower their drug costs, and then help with other costs of their medical treatment. Again, there are programs that can help pay for medical costs, and then other support, which we'll talk about in just a second. So these are a few different resources. Social services are broken down county specific. So you really have to be familiar with the counties that your patients live in to be able to help them. But benefitscheckup.org will let you go in and enter your zip code, and it'll help you pull resources that are available for your county. And this may be resources to help with food insecurity, resources to help with utility bills, internet access. There's all kinds of things out there that I think not enough people know about that are able to use. That let's say we can't reduce the cost of their medication, but maybe we can reduce the cost of the living so that it balances out. The SSA.gov Extra Help, that is a program that the patient can apply for and get up to $5,000 a year extra to apply towards medications. They do have to qualify for it. And then there's things like needymeds.org, which can help the patient put in the names of the medications that they take and guide them to any sort of assistance programs that are out there for those medications. So what do we do with non-specialty medications? How do we get help with those? I mean, there are copay manufacturer programs through a lot of the inhalers that are branded, but there's also a couple of different resources that we use often, and one is GoodRx. And I put up here kind of a cost comparison for azathioprine and mycophenolate using both of these resources, and this is not using insurance. This is cash pay prices, no prior authorization. This comes in a little bit often with mycophenolate because we're using it as an off-label drug. So if their Medicare is requiring a prior authorization, a lot of times it's not approved because it's off-label and it does not have an FDA-approved indication for that. So we will go this route to help patients get on therapy. GoodRx, price varies for each pharmacy. You type in the drug and the strength and how many tablets you want to distribute. And it will be local pharmacies like Walgreens, CVS, local grocery store pharmacies. You're able to find near you that have a reduced cost. Cost Plus Drugs is a mail order pharmacy. It's made by Mark Cuban, and I'm not just bringing this up because I'm a Mavs fan, but it actually has really good prices, and I've been able to sit with patients and help them reduce prices on a lot of reflux medications, hypertension medications, things like that help bring their overall cost of healthcare down across the board. So they send it at cost. I think it's plus 3%, something like that, and then $5 shipping, but you can put the medication in and see, and you can actually e-scribe directly for most of your electronic health programs or health records. So the last thing we're going to talk about is 340B programs, which is something that was started in 1992. It was part of the Public Health Service Act. That was passed by George Bush, not George W. It is a drug pricing program that helps eligible hospitals and outpatient practices provide discounted. They are able to purchase drugs at a discounted rate so that they benefit from the money that they save, if I can say that correctly. So anyone that uses Medicaid, the manufacturer is able to, drug manufacturers that are part of Medicaid have to agree to be a part of this program. When they allow the hospital to buy the drug at a reduced cost, but the hospital gets the same amount of reimbursement for it, so they are able to pass that saving on to patients. And so the goal of that is either to be able to provide patients medication at either a reduced cost or a low cost, or not even to do with the medications that they're distributing, but to take that extra savings that they're not paying on drugs and use it in other ways, such as free clinics or other ways to serve underserved communities. About 40% of current nonprofit and public hospitals participate. It was a small number at first, and there's been a lot about it recently because the number has grown. I think it's about 1,300 hospitals through the US right now that are part of this program. So this isn't an extra cost to taxpayers, but there is a little bit of talk about how it does affect overall healthcare costs. So this is the website if you're curious if your organization is part of it, wants to be part of it. After the organization is approved and registered, they set up a contract with wholesalers for the medications, and they are charged no more than the ceiling price. So whatever they decide the price of that medication can be, they can't be charged more than that for each of the organizations. The only downfall about it is it's not required, they're not required to cover orphan drugs, which I know we use a bit of. So biggest things I would say is don't let cost of treatment deter your patient from starting on therapy. I know it gets really scary for them when they're trying to cover cost of not only medical bills, medications, oxygen, pulmonary rehab, all the things that we do to take care of them, but don't let them think that there's not hope or that there's not something that can help them. Try to make the most of the resources that you have available, and then if you need help, make sure that you ask for it. Hopefully that there are social workers in your area if you're not able to manage this within your own resources. But that is it. Oh, these are my references, and that's it. Thank you.